let's take it forward.
Yes.
And I would first request, because already we had a discussion on PD and nutrition. And, you know, I have a feeling that since PD is expanding under the Prime Minister's scheme, and for example, in Chennai, all the medical colleges, government medical colleges are involved in PD therapy for the patient. They include patients belonging to the lower socioeconomic strata. So are we giving them enough nutrition? Do they need nutritional assessment? And are they getting complications of malnutrition? So these are the issues which we have to look at. And when I worked in Madras Medical Mission and Sri Ramachandra Medical College, we have done nutritional assessment in our PD patients, and we feel that there is a lacuna of nutritional therapy, and by intervention by a nutritionist, definitely after 3 months there was improvement in the nutrition status of the patients in a tertiary care center where middle class patients are being taken care. So can I request Dr. Sarath Kumar, my esteemed colleague from Northeast, to express his opinion and what are the concerns he is facing. Sarath?
Yes, thank you very much, Dr. Georgie. Can you hear me now?
Yes, I can hear you.
Okay. Good evening to all, and thank you very much for inviting me to this panel discussion. In fact, because of the pandemic, we have a lot of problems, especially in practicing PD now in the Northeast. And though the pandemic,
I think we lost him there.
Sir, please unmute, sir, please. Unmute, sir,
hello?
please. Yes, sir.
Can you hear me?
Yes.
Oh, the problem is, as you have mentioned, the Prime Minister's National Dialysis Program has been also initiated in Manipur and the Northeast. But unfortunately, because of this pandemic, my patients on PD, they are still yet to get the free fluids from the government. Maybe the government is taking time because of this pandemic situation. And that is one point which I would like to highlight in this panel discussion. The other point is that this pandemic has become a boon, at least in disguise, for these patients on PD, because they can still continue doing PD at home. And in fact, we are still doing PD regularly during this COVID period also, and we have some papers prepared for publication. The other point you have pointed out is regarding the nutrition. As all of us know that the Indian people, especially the poor BPL patients, they are already malnourished. And as we all know, the PD patients lose more protein as compared to these HD patients. So definitely they will need nutritional support and a nutritionist to assess their nutritional status, and if required, supplement their nutrition. So nutrition plays a very important role in the management of PD patients, especially in the Northeast. Thank you very much.
Can I ask Ram, because Ram's perspective is different in South India. Professor Ram, you know, can you address now?
Yes, sir. When I was asked to be a panelist, I referred on PD in textbook, sir. The textbook says that 16 to 56% of PD patients, they suffer from malnutrition. They call it as protein energy wasting. But when I observed in our patients, more than 90% of them have this protein energy wasting, sir. This can be divided into two types of malnutrition, sir. Type 1 malnutrition is because of anorexia and difficulty in intake of the food. The difficulty may be because of lack of the availability of food, or lack of wherewithal to get the food, or it might be due to anorexia. type 2 is mainly related to the malnutrition that is caused by inflammation, sir. Both this type 1 and type 2, even though they are not watertight compartments, at least in our population, in our patients, both of them are overlapping, sir. Overlapping to the maximum extent, as much as I can notice. The patients, the moment they go on PD, they would develop anorexia, and sooner or later they will deteriorate into some kind of an inflammatory status. The inflammatory status is inherent to the PD. That's what I observed, sir. Even though the patients have not suffered peritonitis, inherent to PD, there are some catabolic stimuli, something like an endotoxin, something like a plastic tubing releasing peptidoglycans because of high glucose metabolism. The patients by themselves, even though there is no peritonitis straight away, even though there is no catabolic stimulus in a PD patient, they also do suffer from some kind of an catabolism because of other reasons. So the moment patient goes into goes on to PD, first it's in a type 1 type of malnutrition, which sooner or later deteriorates to type 2 type of malnutrition, sir. The management of type 1 malnutrition appears to be easy because it's only in a kind of an encouragement to the patient to take more food. But management of type 2 is difficult because it is inherent to our PD system. But it's difficult to differentiate, or it's difficult to separate these two out, and it's difficult to it's so much of overlap is there between these two. It's difficult for us to manage, sir. This is starkly obvious in our patients. Most of our patients are dependent on state government program. We have 175 patients on PD as of now. Majority of them are dependent on state government support, sir. They have the PD bags available free to them, and they also get some amount of pension for a ESRD that is awarded to ESRD patients. But they lack wherewithal for a good food, good high protein food. You know that nowadays high protein food is very expensive. They lack wherewithal for the high protein good food, and they all suffer from inflammatory stimulus. This is my opinion.
Okay. Next, let me have Hema Malini, being a senior dietitian and nutritionist, give her views, and then we will go back and discuss. Because, you know, as far as I know, I have been using in androgenic steroids, decadurable in patients with malnutrition, especially those who are on peritoneal dialysis, and also to improve their appetite. I've been using Mahans or megestrol acetate 40 milligram tablet to improve their appetite, and also look at their adequacy of dialysis, because sometimes they may not have adequacy of dialysis, which may be a factor suppressing their appetite. So, and supplementary food, either kitchen-made food or food which are commercially available, commercial preparations. So I would like Hema Malini to comment on this and their observations and how we can take our Indian PD patients forward. Hema Malini.
Thank you, Dr. Jari sir, and good evening to all over there. And it's been a pleasure for me to interact online on this topic. As we have been discussing, nutritional status is a very important component that we need to look at. And again, we have been deliberating about the tools that will be used for assessment of the nutritional status, which could be SGA, which has been patient-generated SGA, which has been proven to be very good, and followed by that is the MIS, malnutrition inflammation score, also seems to be much useful in case of assessing the malnutrition status among the dialysis patients, also including the peritoneal dialysis patients. Again, the incidence of malnutrition is pretty high here, multifactorial. It could be the PD itself, and followed by the loss of appetite by the as far as the patients are concerned, and the mental agony that they go through, and multifactorial, as we said. So the challenge for the nutrition is pretty high, because with the given scenario of poor appetite and the PD involved inflammation and so on, what to give and how to give becomes a major challenge for us. Yes, high protein, we can go up to 1.5 to sometimes it goes up to 2 grams depending on the protein energy wasting severity. But the question comes in meeting these requirements. Estimating the requirements, while it is pretty easy based on the weight and other guidelines, but meeting these requirements are really challenging. So, as we have been discussing, one is the cost factor. When I have to choose for the oral nutrition supplement, the patients are really worried about the cost involved in it. And the second thing is the lot of restrictions, which is normally, though we say PD patients can be kind of a little bit liberalized on the nutrition support. It is like, imperative that the mindset of the clients are really such that they don't want to include a lot of food items. We see both the spectrums. On one hand, some people are really enthusiastic and they eat a lot and probably get into obesity. On the other hand, there are other group of people who does not eat because of the restrictions that they are worried about. The potassium rich food, the phosphorus restrictions and so on. And the protein, when it comes to the renal failure, the kidney system as such, everybody worries about the protein. And there is, generally protein restriction, they continue to follow. So these are the areas where we need to focus upon. And protein, when we estimate anything between 60 to 70 grams on an average can be considered, which can be given using a regular household protein, the kitchen protein sources, which vegetarian and non-vegetarian sources, and both of them seem to be really useful in terms of going into the anabolic state. It is not that we have to look at only for the non-protein sources, because when we say about the non-protein, good quality proteins, it is the question of the essential and non-essential amino acid combination. So when we are able to make a good combination between the essential amino acid and non-essential amino acid, but from the vegetarian sources, we should be able to give what is required to the clients. So that is one. Wherever it is required, a good oral nutrition supplements also helps us to plan the menu without really burdening on the socioeconomic profile, at the same time trying to meet the client's requirement. Not much we have used on the textured vegetable proteins, but that also comes into one component which we can consider about.
Hemamali?
Yes, sir.
My questions are, how do we help our patients with peritoneal dialysis? Because I still recall one of the best articles published from Sanjay Gandhi Institute in Peritoneal Dialysis International, authored by Narayana Prasad, looking at the inflammatory status and various other parameters and looking at their survival. So I don't think that we have made much headway in terms of educating our patient and improving our nutritional status, because they need carbohydrate, because 60% of the glucose in the dialysate is absorbed, and that produces some calories. But however, the protein intake, we all know that in peritoneal dialysis patient, the intake of protein should be 1.2 gram per kilogram body weight. And during peritonitis, it should go up to over 1.5 gram per kilogram body weight. And we all know that 50% of the protein should be of high biological value. And we found that despite advice and nutritional counseling, many of the patients fall short of taking high biological value protein. And the other issue is that some of the patients, they complain about when the abdomen is full with 2 liters of fluid and the extra ultrafiltrate they have early satiety, and hence they cannot tolerate the food quantity as well as quality. So those patients, we advise them to do the exchange, drain the fluid and leave the abdomen empty, and then let them have their meal and then fill it up. And also, what do you think about, the assessment? Because we need to assess these patients. See, many of the places, the assessment is difficult. The tools, we do not have the tools. So what are the minimum tools you think, Hemamali, which should be applied in looking at the nutrition status of the patient? And also, I would request Sarath Kumar and also Ram Raipu to see that what are the tools they are using in assessing the nutrition status of the patient, because the patients belong to different socioeconomic status. Hemamali, you could start with.
So nutrition status assessment, the tools that we can use is the PGHGA, as I was just mentioning, sir, and also the MIS, Malnutrition Inflammation Score tools. Nevertheless, when we look at the client, when we do the regular clinical examination also, the wasting, if there has been muscle wasting, or weight, there is no weight gain, there is a subsequent weight loss and inadequate dietary intake. That is what is by the dietary record or dietary recall that we as nutritionists will be able to look at what has been their intake and how it is affecting their nutritional status. So the dietary intake and the routine parameters of biochemical profile, wherein in addition to the BIA. The BIA seems to be a good tool also for assessing the nutritional status. So a comprehensive tool combining of any of these should be able to give us the actual nutritional status complemented by the dietary assessment. It is very, very important that we need to look at so that I will understand how much they are eating and how much I should be able to manage with.
Professor Sarath Kumar.
Yes.
Yes.
Yeah, we do practically the clinical assessment, the dietary history, what kind of food that patient has been taking, his appetite status and all that. In addition, we do a simple serum albumin test and then also know the nutrition status. And many of our patients are found to have malnutrition despite having, say, good nutritional supplementation. So maybe malabsorption also could be a problem in these patients who are on PD. And of course, you have mentioned about the loss of appetite, maybe inherent to PD itself. So many of my patients, we do in clinical practice follow the simple albumin test. And then if the albumin is below the desirable level, then we would ask them to take more food and then nutrition so that they can supplement their nutrition. That's what we do.
Professor Ram Raipur.
Yes, sir.
Ram.
In majority of our patients, they undergo subjective global assessment and serum albumin check, sir. That is done almost once in 3 months. Albumin is in fact done once in a month, sir. And subjective global assessment is done somewhere between 3 to 6 months, sir. We have a peritoneal dialysis nursing course, and these two nurses per year are there. These two nurses do that job, sir. And in addition, our institute also has a DEXA and bioimpedance, which we occasionally send our patients. In addition, anthropometry, sir. This anthropometry is also regularly practiced at our institute, sir. These nurses, they do anthropometry also. This is the minimum assessment, and as I told before, 90% of our patients are malnourished, sir.
Now the question comes, we all agree, universally agree that our patients are malnourished. Now, since amino acid containing fluid, dialysis fluid 1% is not available in the country, and I don't think that our government would supply that for our patients. So Hema Malini, I am coming back to you again. What can we, in terms of nutrition, by reducing the phosphorus protein ratio? Because it is well known that in peritoneal dialysis, the removal of phosphorus is about 300 milligrams, and about in hemodialysis is about 360 milligrams. So what should be, so to achieve that, there should be adequate dialysis, and also the phosphorus protein ratio should be less than 12 milligram of phosphorus per gram of protein. So Hema Malini, can you just highlight us, in your view, as a leading nutritionist in the country, what could be the advice we could give to patient who comes on outpatient basis for nutrition, for PD and PD or outpatient clinic, and how do we take it forward? Hema Malini. Hello, Hema Malini. Hello.
Yes, sir.
Yes.
Yes. So yeah, phosphorus is major concern, but what we are looking at is the phosphorus content comes mainly from if a client is taking generally the processed foods, the regularly available from the food groups. If I look at the cereals, millets, the proteins, and the other fruits and vegetables, relatively the phosphorus content is low, and we should be able to plan the menu within the 2000 milligrams of 800 milligrams of recommendation. So it is not actually a tough proposition to cut down the phosphorus while we are improving the protein intake with appropriately tailor-made regular diets, and we can control the high phosphorus foods which is from the non-vegetarian sources, and then it should be easy for us to manage. Actually, as you were mentioning, doctor, it is like counseling the client that makes a lot of impact. They are pretty much confused what to take and what not to take. So I would suggest that a routine balanced diet where we will be cutting down on the pretty high phosphorus foods, which is predominantly from the processed sources rather than from the regular natural foods. So when we make the diet tailor-made to this level, I'm sure the phosphorus content can be maintained to a ratio, protein phosphorus ratio, and still may help the patient to improve the nutritional intake and also the nutritional status.
Great. Since we are short of time, I think we would like to wrap up by saying that majority of our peritoneal dialysis patients are malnourished in terms of protein malnutrition and also protein calorie malnutrition. Number two is that we are not sure about their adequacy of dialysis, because a lot of the time we do not look at the numbers for adequacy of dialysis, and also we do not count their bags whether they are doing 2 exchanges a day, 3 exchanges or 4 exchanges a day, despite the government providing them the dialysis fluid. Third thing is that there is a critical gap in the patient's understanding of nutrition in peritoneal dialysis, and they think that probably by putting instilling the fluid in the peritoneal cavity, they get enough nutrition. And also we need to do a nutritional assessment, and as Professor Ram said that they have all the new tools look at nutrition status, but in the general population in government medical colleges, these tools may not be available. So the nephrologists and the nephrology PGs and whatever help is available from the nutrition should be utilized to take care of these patients. And in my understanding, I also would feel that the inflammation may be a factor, as some of you mentioned, and this inflammation has to be looked at, and this anti-inflammatory drug may be of use, probably pentoxibulin or something like that. And to improve the appetite, the exchanges should be done with the peritoneal cavity MD in those patients with the early satiety. And also the use of micronutrients may be essential in patients who are on peritoneal dialysis. Is there anything more which we have to do? We have to look at. I would request the panelists with one word, and then we will wrap up.
I think the time is getting over. Yeah.
Yeah.
Thank you.
What I suggest is that the malnutrition could only be prevented, sir. Once malnutrition sets in, the treatment of it is very difficult.
Agreed.
Yeah.
Okay. Thank you.
Yes. Yeah, it is from the team, from the healthcare team point of view, the nutrition counseling and individualized dietary plan with not too much of undue restrictions. I feel that would help the patients to realize the importance of nutrition and help to prevent malnutrition. That's what I feel. Thank you.
Thank you. Thank you. And
we
should have the platform left for the next session. Thank you so much for all of you being here and expressing your views on Indian peritoneal dialysis patients. Thank you once again.
Thank you, Georgie, so much. And your
thank you, Umesh.
Thank you. Yes.
Thank you for all the esteemed panelists for giving us this